Hello, this is Sarah Al-Shaker. I'll be presenting the surgical management of a case of scleral melt. This is an 85-year-old male who has a known history of rheumatoid arthritis, which was well controlled on Xeljanx. He was referred for a persistent leak through his superior extracapsular cataract extraction wound, despite having been sutured twice. His symptoms were flashes in the left eye for a few days, blurriness. He denied pain, and there was no history of trauma. He had underwent cataract extraction in the right eye in 1990 and in the left eye in year 2000. His examination was significant for decreased vision in the left eye with low pressure and also a Seidel positive leak through a scleral defect superiorly. The eye was soft, there was cell in the anterior chamber as well as vitreous. However, it was a hazy view and we couldn't appreciate if there was a lens. So while the referring physician thought that this patient had a dehisced Ecce wound, possibly due to the fact that the patient was aphakic in the other eye wearing rigid contact lenses, there are three diagnostic clues to tell you that this patient does not have a dehisced wound. 1. The history of rheumatoid arthritis. 2. The patient had his surgery in the left eye in year 2000, 10 years after the introduction or popularization of phaco. 3. The patient was leaking through both the sclera and conjunctiva. This indicates that this is a melt rather than a dehisced wound, which will filter through the sclera but not necessarily through an intact overlying conjunctiva. So our impression was that this was scleral perforation, secondary to necrotizing anterior scleritis with inflammation in a patient with known rheumatoid arthritis. The patient was taken emergently to the OR that night to repair the scleral melt. He was also given an IV Solumedrol pulse intraoperatively. We also started him on topical antibiotics, steroids, as well as atropine to deepen his AC. A course of oral prednisone was given with a rapid taper, and he was referred to rheumatology to titrate his steroid-sparing immune suppression. We also started melt treatment in the form of doxycycline and vitamin C. In this video, we describe the surgical approach to managing this case. First, we identify the leak superiorly, and you can appreciate the vicral sutures from the prior surgery as well as the Seidel positive sign. Then we perform a localized peritomy to expose the area of the melt. Through a defect in the sclera, we inject viscoat to tamponade the vitreous in the AC. Then we suture close this hole, although we know definitive management will require a patch graft. Next, we measure the area of the melt, and that is defined by the area of the sclera that is necrotic. So you measure up to the boundaries of where the sclera does not bleed. That is the size of the graft that you require. Next, we prepare the corneal button by punching the size you measured. We take it back to the patient to decide on further trephination. Here we use a punch to create a crescent-shaped graft. Then we remove the epithelium and the endothelium by scraping it off. We take it back to the patient and thin the edges that allows a secure fit when we suture it down. 10-0 nylon interrupted sutures are used to secure the patch graft. Then we perform an anterior vitrectomy to deal with the vitreous in the anterior chamber. Finally, we need to bring on vascular supply to this tissue. In this case, the adjacent tenons and conj were healthy and vascular, so we pulled them over the graft and sutured it down with 8-0 Vicryl. This is how the patient looked at the end of the case. So in summary, necrotizing scleritis is a medical condition that can be controlled with immune suppression. Ideally, this never progresses to become a surgical condition. However, if it does, then remember that surgical management is there to provide tectonic support to allow time for the medical treatment to regain control of the situation. An important concept to remember when repairing necrotizing scleritis is that this is essentially an ischemic state. The underlying histopathology is a granulomatous inflammation with necrosis and ischemic vasculitis, which leads to a deprivation of the blood supply in the sclera. Remember, when we measured the graft size, we sized it to the area of a vascular sclera. Understanding this will
remind you to always bring on vascular supply for the survival of the graft. Often, a posterior tenon flap is dissected and brought forward. This is in contrast to a PUK, when recessing conjunctiva helps decrease the influx of inflammatory mediators.